we've got a lot of options that we've talked about today, the docetaxel, the docetaxel, the afatinib, chemotherapy options. What is the right sequence? Is there a right sequence as we finish up here? What is the first, second, third, fourth? And we're excluding clinical trials here. All of us participate rigorously in clinical trials, but is there a right sequence here, or is it just individualized, as Ed, you've said before?
Today or a year from now?
Let's go today.
Okay, so you know, I had a case years ago where I had a young lady who had squamous, very odd, and they thought it was small cell. They gave her 1 cycle of carbotopicide. It didn't work. And then they said, no, it's squamous. And for some reason, they gave her carbotaxol Avastin for 1 cycle. She survived that. And then she came to see me. And she was in bad shape. She was on oxygen, 39-year-old mother, single mother, had a young child. And I said, you know, this is time where we just got to go for the gold. This is no way a pattern of what you should mirror from this. But so I, at the time, said, let's try, if we can get them, carboplatin, nab-paclitaxel, and cetuximab. And those are the guns, right? I mean, that if you're looking for getting somebody, and so today I would imagine, I would love to use a carboplatin, nab-paclitaxel, necitumumab frontline. And I know that study's being done, but you know, if you want to try and stack some efficacy, seeing what Neci did with this Gem-Cis on top of what Abraxane does on its own, I think that's really quite interesting as long as it's safe to give. But right now, you know, we go with Abraxane-based regimens up front, and that's our default. So to me, it's in light of down the road, integrating a checkpoint inhibitor, it's carboplatin, nab-paclitaxel. Then in second line, it's nivolumab, and then consideration of a docetaxel RAM strategy versus something less intensive.
I think that would be where we are in line too. We generally start, all of our patients have been offered the Abound study with carboplatin with maintenance Abraxane, followed by, we have a checkpoint inhibitor study as well, but outside of that, again, the carboplatin immunotherapy, followed by dosi-ram. I would argue that a lot of our patients who get to third line may not be eligible for dosi-ram. Those patients, maybe I would consider a TKI depending on how they look. Maybe I would consider another cytotoxic single agent drug. And then transition from there. Paul, your final thoughts on sequencing overall?
Yeah, the sequence is similar. I tend to be a little bit more agnostic in terms of the first line chemo regimen, in part because looking at the overall landscape for the research portfolio also, these things sometimes need to be taken into consideration. But I think it's perfectly reasonable. I think the preferred regimens are carboplatin if you go down a taxane route. Carbo-Gem, I think, is perfectly reasonable. You know, a lot of the patients we end up seeing are opinions, second opinions, third opinions for what's been going on. And I think, you know, we have to be careful in terms of what the data show for what any individual oncologist has recommended. And, you know, when you, again, look at the data for first-line regimens, there's not a lot that you can stand on in terms of the differences. I think, again, immune checkpoint inhibition, absent an autoimmune disease or being, you know, never smoked, which is unusual for squamous lung cancer, certainly is in the second-line setting, then, you know, chemo-ram. You know, for me, dosi-ram can be a little bit limiting. I would love to see at some point data for gem-ram, for instance, you know, something like that. Whether we'll ever see that, you know, whoever knows, but it would sort of free up options also, particularly since it's a single-agent gemcitabine, you know, is not very great. I agree, though. By the third-line setting, sometimes dosi-ram is hard to get, for full-dose dosi. Certainly, the Q3 week and even divided weekly, which is better tolerated. I find dose reductions for the dosi are required a lot by that point. But, you know, I've seen responses, and so, you know, it certainly is reasonable to give with an expectation of, you know, some degree of response, I think. And then after that, of course, then you know, you're far afield. Right. And that's where we just got to get better in terms of the work we're doing, all of us, yeah.
Great. So this has been a terrific discussion. We've discussed a lot of information about the latest in the treatment of squamous non-small cell lung cancer. Before we end this discussion, I'd like to just get some final thoughts from each of our panelists. Dr. Kim, final thoughts on today's discussions and where we're heading.
Yeah, well, I've enjoyed the discussion. I always like talking about practical clinical aspects engrossed with the science. And so the bottom line is that there are many more options for patients who have squamous histology, lung cancer. We're definitely moving in the right direction. We have more options for treatment, but we still have to sort out stratification with biomarkers and enrichment. The science and the trials, I think, are built to answer some of those questions. And as I had mentioned before, we need some serendipity as well. We need to accidentally find someone who responds really well and figure out why they did and see if we can find that marker. So I'm very pleased with the direction it's going.
Paul?
I think I mirror that. I mean, the fact that we've gotten so many new agents approved in effectively a year's time, I mean, that's unprecedented, really. And yet, if we look at lung adenocarcinoma as the cousin, right, or the sister or brother, they're far better off. And they're far better off, by and large, because targeted therapy is reality for them. And so for me, despite the excitement with immune checkpoint inhibition, I still think that this is an untapped arena and something to keep our eyes on and something that should remain a focus, not just in combination, again, as the tendency is, I think as you've mentioned, to do willy-nilly combinations with targeted therapy that may or may not make sense, but actually, really honing in on combinations that make sense in order to really gain, see these gains that we've seen with other TKIs and lung adenocarcinomas.
So I would agree with you both that the amount of options we have supported by science is tremendously exciting for patients with advanced stage non-small cell lung cancer, specifically squamous cell. I'm going to take the approach that I always do in my final thoughts and really just remind people that these treatments, unfortunately, despite the excitement, are palliative in nature, not curative, and we really have to be on the forefront and leading the discussion about preventative measures for lung cancer. Smoking cessation for patients who are smoking who have not developed lung cancer, and also CT screening, picking up these cancers early. Clearly, a little bit different approach than what we've been talking about today, but we do need plasma enrichment strategies for patients who have nodules on scan. So yes, tremendous excitement with all the drugs. I'm one of the people who has welcomed these with open arms, but I think medical oncologists also have to lead a discussion with their primary care physicians about how to prevent this disease from happening from the first place. So on behalf of our panel, we want to thank you for joining us.